So before I start, want to extend a warm welcome to every participant. And if you take a minute to download this app on the Play Store, it's called World Health Organization Global TB Report, then that would be useful for our lecture. It's a useful tool. And today being the World TB Day, I think it's an opportune moment for us to discuss about tuberculosis. So the theme for today's topic will be about old tools and new challenges. We will talk about why am I using the terminology old tools and new challenges as we go along the lecture. And we'll focus more on the TB elimination program in India and what it means for the TB elimination program at this juncture of time. So I've split the lecture or the seminar in few parts. The first part, I'll just briefly go through the basics. I know a lot of people have a medical background and some of you may not have. And the people who have medical background, they have usually would have read about the microbiology in year 2. So it's just a brief brush up, but just want to start with the art piece here. This portrays a picture by a participant, by a person who's sitting next to his sick wife, who's been affected by tuberculosis. It was drawn somewhere around 1940s, 50s. And you can see what is more striking is that you can see the environmental conditions of these two characters in the picture, and you can see that they're living in a very impoverished condition, and they look very malnourished. So this just to highlight that TB is not just a medical disease; it is a social disease, and it is become more relevant at this point of time. We know that there are multiple infectious agents for tuberculosis, and the most important is Mycobacterium tuberculosis, which causes pulmonary tuberculosis and extrapulmonary tuberculosis. And they're usually acid-fast bacilli, and it's visible in the modified Ziehl-Neelsen technique as pink rods. And droplet infection is the usual mode of transmission. And usually person-to-person transmission occurs from sputum smear positive patients and laryngeal TB. And particle size less than 0.1 micrometer tend to get suspended, and they are able to reach the alveoli. And you also can get you can also get tuberculosis by ingestion of unpasteurized milk. Humans are the primary reservoirs for tuberculosis, and you can also get tuberculosis through cattle. But fortunately, we boil the milk these days, and we also have pasteurized milk, and therefore we see very little TB from the cattle, which is called bovine TB. But there are some incidents where TB can also be contracted through animals like elephants or other animals. So, but humans are the primary reservoirs for tuberculosis. This is a very important slide, and basically it just gives you what happens when you contract TB bacilli. In the top half of the slide, you'll see a man or a woman injecting Mycobacterium tuberculosis bacilli into the lungs. So once it goes into the lungs, it goes into your alveolar sac. And the first line of defense is usually your alveolar macrophages and then the phagocytes. And they actually are the first line of defense. They try to control the TB infection, which you can see as pink rods. or rods, like dark purple rods, and they kind of form like a shell. And once they are not able to, contain it, then they call for more help, and that's where monocytes and dendritic T cells come and try to help our immune system. So, in spite of that, the Mycobacterium tuberculosis bacilli can outnumber the immune system, and then they start breaching the alveolar spaces. They go into your lungs, and then inside the lung, what happens is the body forms a shell. So basically, the enemy has come inside, and the T cells, B cells, and all the macrophages, they surround the tuberculosis bacilli, and they form a shell, and they go into a state called they form like a granuloma, and then they go into a phase called latent TB infection. So that's what it's written on the left top hand corner. And so once you contract TB bacilli, nearly 1/3 of them, nearly 95% of them go into a state called latent TB infection. Okay. And this is very important from the perspective of TB elimination. So as I told you, 95% of them, they will, if they contract TB bacilli, they go on harboring TB bacilli in their body, and then they go into a state called latent TB infection. And from latent TB infection, there'll be no signs and symptoms. But if the immune status alters, if they become old, if you have risk factors like HIV, diabetes, smoking, indoor air pollution, malnutrition, all of that, then what happens is the TB bacilli can come out of the granuloma. They breach that granuloma shell, and they come into the lung parenchyma, go back into the blood supply of the lungs, and then they come into the bronchus. And when you cough, then the TB bacilli comes out. And that's how you spread TB bacilli from one person to another. It's just a very simple diagram, but very powerful diagram, which illustrates the immunology of TB. And the next most important picture I want to show you is this natural history of TB. A very important slide, because this shows you what happens if someone is not getting treated. So like I showed you in the previous slide, on the top left corner is the Mycobacterium tuberculosis bacilli. You inhale that, and 95% of them will go into a state called latent TB infection. And of those people with latent TB infection, 5% will, in their lifetime, will go into active TB disease. All right. So that's a very significant portion. Like say, World Health Organization estimates that nearly 1/3 of the world's population has got latent TB infection. And in my PhD, I did a survey in Vellore, CMC, in association with CMC Vellore, and found that 50% of the household contacts and 50% of community members had latent TB infection. So you can see the latent TB infection burden is very high in a country like ours, okay, because we have very high infection burden. So if you screen 50% of them with tuberculin skin test, you will have half of them will have latent TB infection. So of those with latent TB infection, 5% will go on to become active TB disease during their lifetime. Because it's very important to know that. And imagine this. So if you have active TB disease, and if you don't treat people, 50% of them will die. So that's an important point you have to remember. The next important thing is, if you treat someone with active TB disease, 95% of them will get cured. So that's amazing to know that if all you have to do is diagnose people with TB and give them appropriate treatment, and 95% of them will be cured. So we have a magic bullet with tuberculosis. All we have to do is diagnose them at the correct time and treat them appropriately, and 95% of them will get cured. And that's really good. So the next question we ask is then, why do we have so much TB in around the world? And that's where we're going to discuss. So among those with active TB disease, the 50% will have can transmit. If you have a sputum positive or you have a laryngeal TB, 50% of them will transmit active TB disease. Now, another interesting point you have to remember is the transition from latent TB infection to active TB disease changes drastically if someone has got an immunocompromised state. For example, you're taking immunosuppressive drugs for your arthritis. You have immunosuppressed conditions like HIV or diabetes, or you smoke. You have indoor air pollution, which constantly damages your lungs. Then your chance of progressing from latent to active TB disease becomes very high. So very simple and a powerful slide just to illustrate the natural history of TB. There are many risk factors for infection and disease, and we have already narrated some. Some of the most important things are proximity and duration of contact. For example, health workers such as us and household contacts, we are at a close contact with people with active TB disease, so we are at very high risk. And then other risk factors like age, extremes of age, children, older people, gender. There was one study which showed male gender had a higher chance of getting active TB disease. Sociologically, males tend to move out a lot and they have a better health-seeking behavior. So that's one of the reasons quoted from the social studies. And of course, the immune status, malnutrition, and diabetes are other risk factors. So you just have to understand these risk factors and know that they all increase the chance of progressing from exposure to infection to disease. So another thing from a public health perspective, we have to understand is that diseases are not just medical problem, it's a social problem. And I think we all know that as health professionals, social determinants play a major role, whether it's environment or your financial status, all of that socioeconomic factors, all are very important. And I think we have to understand that social determinants play a major role in tuberculosis, including factors like stigma, all of that plays a major role. And along with that, there are some other unique factors which play a major role in tuberculosis. One of them is population growth. And as population grows, you have more people getting exposed to infection, bacilli, and then more people getting progressed to latent TB infection. And then there is a big group of people waiting to become active TB disease. So all of these are important. And some of the things which are vital from an Indian perspective is rapid urbanization. We now know that urbanization is occurring at an unprecedented manner. Nearly 50% of our population now starting to live in urban areas, and a lot of people are moving to urban areas for want of jobs, for seeking better life opportunities. And people who move from rural to urban areas usually start staying in shanty tins and in the peripheries of the cities without proper healthcare facilities. So that becomes a big problem. So rapid urbanization, population mobility, socioeconomic inequality, and of course, climate change also plays a major role. So I think social determinants are very vital. I think it makes sense for us to take a grip of these social determinants, especially in terms of tuberculosis. So that's just a brief overview. And I'll just run through some clinical features and some diagnostic tests and treatment. So one of the important feature is, we all studied that pulmonary disease causes chronic cough, productive sputum hematolysis, weight loss, night sweats, fever. These are all standard clinical symptoms, but you have to understand that most of the TB cases will actually present with a lot of atypical features. So recently we see a lot of cases with comorbidities like diabetes. They usually come with tiredness, dull body pain or even fever, low-grade fever, and you go test for tuberculosis, they do have tuberculosis. So you'll have to understand that a lot of TB now presents with atypical features. Another important point is that extrapulmonary TB presents pertaining to the TB site. It is present. For example, you have TB in the spine, you'll have back pain. If you have TB in the meninges, you'll have headache. If you have TB in abdomen, you may have ascites. So it's a very location specific. So all of that depends on the site where TB is present. And another important point you have to understand is that TB affects every single part of the body. There are no places where TB is not affected. To diagnose TB, we still use sputum smear, and we also now started using a lot of a new technology called expert TB, which is basically a PCR or a NAT test, and it does give a very good sensitivity and specificity, and that's being now deployed in many DOT centers, in many diagnostic centers. But the gold standard is to do a sputum culture, but usually it takes a long time. In terms of genotyping, it's not commonly done, but it's very useful in Western countries like where I live. In Australia, it's a routine test to do to understand the genotyping. But for the Indian perspective, we do use NAT test, PCR, or expert MTB, where you find resistance for single drug, either isoniazid or rifampicin, because that gives a 70-80% sensitivity range against the drug. So a very good test, but it's now being widely deployed in India. To diagnose latent TB infection, you need to do tuberculin skin test. Now, if you look at the first slide, I told you we're using old tools. So if you look at chest X-ray, which is very commonly used, it was discovered by Röntgen in 1870s. And if you look at tuberculin skin test, it was discovered sometime in 1930s or 1940s. Sputum smear again. Robert Koch discovered this in 1860s or 70s. So all of these tools are, the mainstay of diagnosis, and you can see that we are using that even today. There's not been a lot of progress in terms of diagnostics. And then just want to focus a little bit on the TB drugs. I don't want to go through each and every one, but just want to highlight the year of discovery of these drugs. You can see that isoniazid was discovered in 1952, rifampicin 1963, ethambutol 1962, pyrazinamide 1954, streptomycin 1949. The first top 5 are the most commonly used first-line drugs, and you can see they have been discovered in 1960s. And there's not much of a drastic improvement in the TB treatment strategies. We have not used new treatment drugs. So, Dolly, it's not a joke. 90 பேர் இருக்கிறான், please. Sorry about it.
No worries, no worries.
So there has been a lot of drugs, but we know that all of these drugs are old, and not much of investment has been made in terms of discovering new drugs. If you look at contrast this with HIV, you can see that every 6 months there will be a new drug for HIV, and this is a very important comparison statistic, because HIV mostly affected Western countries, and a lot of money has been pumped into the new drug discoveries, and whereas TB has traditionally affected low and middle income countries, and very little money has been devoted to R&D of new drugs. So you can see that we still use old diagnostic tools and old treatment strategies. So the way we want to treat TB is that we want to attack TB with 4 drugs for 4 months, and another 2 months we want to give 4 drugs. And the why we give multi-drug therapy, most of you would know, it's because we want to kill both fast-growing and slow-growing bacilli. And it's very important that we do this. Otherwise, what will happen is people will develop drug resistance. So that's the reason why we give multi-drug resistance therapy. So this is the current recommended schedule. And if you can, it's very important that we follow this treatment schedule. The reason is simply we want to avoid drug resistance. We do give vaccines for TB, but you have to know that vaccine's not fully effective, and it only helps in preventing serious forms of disease in young children, especially miliary TB and serious meningeal TBs in young children. So in Western countries, they don't give vaccine as a routine in high-income countries, but we do follow that in low and middle-income countries. WHO recommends that, in spite of its limited impact on control of TB, because it does help severe forms, or in preventing severe forms of TB among children. So this is the test I was talking to you about, the expert TB test, and it's now being rapidly mobilized in many DOT centers. I think they covered more than 40–50% of DOT centers in India, or maybe more than this at this stage. It's really good because you give a sputum sample and you get the results in 2 hours, and it detects it's a molecular test which detects DNA in the bacteria and also detects genetic mutation associated with rifampicin. And there are lots of advantages. The only disadvantage is that it needs to have a constant power supply, and you need to have a technician who needs to read these tests. So one good thing is there are lots of new drugs which are now being developed in the pipeline, and lots of new diagnostics which are coming up, and newer vaccines are also in the pipeline. But all of this are not enough, but we need to do a little bit more in terms of TB control, and we'll see why it's really important as we see the numbers. So let's go into the epidemiology. And if you all have your app, if you have downloaded the app, let's work through the app, and then we can we can learn through the app also. So just want to, before we go into that app thing, let's just go through this slide. And this is the top 10 causes of disease, top 10 causes of death in the world globally. And this was from 2019, just before COVID, but still relevant. And you can see that in this, the top maybe 15 causes of death in the world. If you see tuberculosis, actually, it's ranked 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So 13th in the rank. So the interesting thing I want to point out is that if you compare this with HIV, HIV is right in the bottom. And the numbers are not very clear, but the number of deaths caused by TB is actually double the number of deaths caused by HIV. So it's very interesting to know TB is the single largest infectious agent causing death around the world. And it's a very serious problem. And a lot of people do not actually pay attention to this. To quote the exact figure, in India, 1,400 people die every day. So as we are speaking today, March 24th, 1,400 people have died in India because of tuberculosis alone. It's a very serious problem. And just to highlight this, this is very important to know where TB sits in the grand scheme of things. This is another slide which shows the TB incidence rates. Basically, you can see that India is in a darker green zone, roughly about 150 to 180 per 100,000. So every year we get 3 million estimated cases, and we will talk a little bit more. But just want to highlight that in terms of new cases, India is still not as bad as African region, where the incidence is very high compared, roughly about 354, something like 350. And still we are doing better, but I think we still have a long way to catch up. In terms of the global epidemiology, we have about 10.6 million new cases in 2021. And there's a big jump from so this is 2021 from 2020. And of that interesting thing I want to highlight is that this is a mathematical estimation. So based on, many seroprevalence studies, national TB prevalence surveys, WHO takes the prevalence surveys and they estimate this number. So according to that, there should be let's say 11 million cases. But if you look at the reporting, only 6.4 million cases are actually notified. And this is actually a very important thing to understand. So you have, let's say, 11 million cases occurring every year, but only 6.4 million cases actually getting notified. So when I say notified, which means they are actually coming into the system and they're getting treated. So let's just to for an understanding purpose, let's say there are 12 million cases and only 6 million are getting notified. Nearly 50% are not getting notified. So as per this figure, as per this statistic, nearly 40% of TB patients are actually not getting notified every year. This is every year. So imagine every year burden keeps piling up, okay? So a lot of people are not actually even getting notified into the system. They're not getting treated. They're not getting followed up. So we don't know what's happening to them. So it's very important statistic, very important thing. And it's very useful for us to understand why India is struggling with the problem of TB. And during COVID, there was a big dip in notification. Obviously, a lot of resources were devoted to, controlling COVID. So we were, we funded a lot of money for COVID control. So we didn't have money, or we didn't have resources, manpower for TB, and therefore there was a big notification problem. And there's 500,000 multi-drug resistant TB cases, but only of that 500,000, only 125,000 are detected and reported. And as I told you, nearly 1.4 million deaths happen every year. So of this slide, the one thing you have to take away today is that 40% of TB cases do not even get notified throughout the world, okay? All right. So if you ask which country is the #1 burden country in the world, unfortunately, not a ranking for India. India ranks #1 in terms of global picture. So if you have about 10.6 million cases, 3 million cases occur in India alone, okay? And then we will talk more about that, okay? So let's say, have you guys all downloaded the app? Yes?
I request all the attendees to keep your answers in the chat box or Q&A session.
Okay. All right. So if you guys have the app, then it'll be easy for me to show. But anyways, if you can just scroll through the app and then go to, if you open the app, there'll be like 6 columns. And if you go to region and then click global, and then you will see that there are 10.6 million incident cases. Incidence is new cases and 1.4 million mortality. And that's roughly the population, 7.9 billion population. Now you go back to the main page, and then you click countries and go to India. Okay, all right. So if you go to India, then you will see there are 3 million incident cases. All right. And in that, there will be a lot of tabs. First is the estimates of TB burden. All right. Next is notification. So click on notification, and you'll see that data are for 2021, and the new and relapse cases is 2 million. All right. So WHO estimates that there should be 3 million new cases every year in India. But if you see how many cases are actually getting notified, it's only 2 million. All right. So we will talk more about that a little bit in detail. But let's just leave the app for a minute and come back to the slides. And as I told you, during COVID, all of the notifications in most of the countries dropped, not just for TB, but for all of that. Okay. And let me just skip all of that. All right. And what happened during the last 10 years in the global arena is that we had a sustainable development goal target, and now that has been revised to the World Health Organization in TB strategy. So what they want to do is they want to have 80% reduction in TB incidence rate by 2030 and 90% reduction in the annual number of TB deaths by 2030. So that's the goal they have kept. All right. And have they reached the goal? No. 50% of incidents have been reduced, and the number of TB deaths, and that's really good. They have reached nearly 75% of the milestones. And so those 2 goals are really good. But incidence is not really good because only 50% has been reduced. Okay. Now, before we go through the treatment strategies and why India is why India is struggling with TB elimination, I just want to spend maybe 10-15 seconds on this slide. This is a slide which shows the death rates in England and Wales between 1838 and 1970. And you can see the death rates have been drastically reduced. And you can see in epidemiology, the steeper the curve, the higher the decrease. So you can see the curve is declining rapidly from 1850 to 1940, 50, 60. And if you look at this, only towards the end of this slide, or 1940, 50, drugs were discovered, vaccines were discovered. But even before that, there's been a rapid decline in the number of TB deaths. Okay, so this will be a part of the questionnaire. We will talk a little bit more about this, why this has happened in United Kingdom, and what factors have contributed to this. Now let's look at some of the treatment strategies. I want to highlight these treatment strategies for a particular reason, and you will know at the end of the next 2 minutes. So before drugs were introduced, medical treatment was introduced, you literally have to resect a portion of your lung, and that's called thoracoplasty. And then came sanatorium method of treatment. So where actually people were put in TB sanatoria, and then they were asked to stay for 6 months, 9 months, 1 year. They'll be given medications. They will be taken to morning near windows where fresh air comes. So if you go to Chennai, there is a big TB sanatoria. If you go to Madanapalli in Andhra, there's a big TB sanatoria. And if you go to many places, many cities, you'll have TB sanatoria. Now, one of the important things I want to tell you is that the transition in TB treatment has happened uh, because of the many clinical trials which were done in India, especially through the TB Research Center in India. It's located in Chennai. Now it was called as TB Research Center. Now it is called as National Institute of Research in Tuberculosis. And they did some pioneering studies, which has changed the landscape of TB treatment. So they did a huge trial where they showed that you can treat people at homes instead of sanatoria. They also there was a big trial which was done in the TB Research Center in India, which cut down the treatment duration from 18 months to 6 months. Okay, and therefore some of the leading studies have been done in India. So what the point I'm trying to tell is that India has been a forefront in TB research and never been recognized for its contribution, for its contribution to TB control and TB generation of knowledge in TB research. So the important point here is we have a program called DOTS, and we give treatment for 6 months. The reason why we give TB treatment for 6 months is that it provides a cure rate of 95%. It prevents new infections. It prevents the development of drug resistance, and it's cost effective. And that's the reason why we give TB treatment through DOTS. There's been many studies which show that DOTS is not very effective, but we do follow DOTS because we are very particular that patients should take TB treatment for 6 months so that they don't develop resistance. But new guidelines also allow for a shorter duration for 4 months, but that's not being widely adopted. It's a case-by-case basis. But just for your sake, remember 6 months treatment is the standard one. Okay. And because of the inconvenience caused by directly observed therapy, you have to go to a particular person and then make sure you take the drugs in front of them. Now, WHO has allowed you can even take a snapshot or a video recorded version, and then you can go and take drugs and then record that, timestamp it. So they're making it more convenient for people to take drugs. Okay. All right. So that's pretty much about what I want to tell about the treatment. Now coming back to India, this is the most important area why we are talking today, is that in India about 3 million cases are estimated. We know that statistically, epidemiological studies show that there should be 3 million cases, but only 2 million cases are being reported every year. All right. And that's a big problem. All right. And we'll talk about why that's a big problem. In India, now we have, if you have studied TB a while ago, it used to be called as Revised National TB Control Program. Now it has been changed into National TB Elimination Program. And the government has set up an ambitious target of eliminating TB by 2025, which is about 2 years from now. And the TB program has now reached throughout India. We've got DOT centers everywhere, and we've done fantastic job in reducing TB. But there are a lot of challenges, and that's and some of the challenges we're going to discuss today. Okay, and one of the things which we have to understand is that we have now a very strong framework through this National Strategic Plan for TB Elimination. And it's like a 40-50 page document. If you guys are interested in understanding more about what's the government's vision in eliminating TB, I urge everyone to go and read this in detail. It's a fantastic document, and you will be astonished to see the level of detail the government has put in preparing this document, and appreciate the involvement the government has putting in eradicating or eliminating TB from the country. Okay, so basically they have a 4-pronged approach TB. So it's called detect, treat, prevent, and build. And detect is you have to find all drug sensitive and all drug resistant cases, and you have to initiate and sustain all patients on appropriate anti-TB treatment, and you have to prevent the emergence of TB in susceptible populations, and you have to build and strengthen enabling policies, empower institutions, and build the requisite human resources. Okay, I don't want to go into detail in each and everything and then explain to you, because I want to discuss more about the challenges for TB control in India. Okay, so the three things I want to discuss: the triple epidemic, the private health sector, and the miscellaneous issues. Okay, so first thing is the triple epidemic. So when I was starting in TB research and treatment as a clinician, HIV was a major problem, and we used to call it as double trouble. But now we have a triple trouble. So we all know that TB and HIV, they are comorbid factors, they accelerate each other. But we also have another problem now, which is diabetes, okay? And diabetes is increasing day by day in India. And statistics show that among people with diabetes, there is about 15% of them have, among people with tuberculosis, 15% of them have diabetes, and about 5% of people with TB also have diabetes. So it's like vice versa. Diabetes increases the chance of your immunosuppression and then causes increases the acceleration of TB infection to active TB disease. So it's very important to know that diabetes is now propelling the number of TB cases in the country. And so how do we counteract this? Just like we have National AIDS Control Program, National TB Program, we also have this non-communicable disease program. And though all of these programs have to start cross-referring each other, and government has now introduced cross-referral. And if you read the National Elimination Program strategy, you will see that there's a big focus on cross-referral for these patients. The second important point is private health sector. And you know that in India, more than 70% of healthcare is provided by private sector. In fact, the statistics, the actual ground reality is that more than 85% of healthcare is provided by private healthcare. The key thing here is it's unregulated, it's unorganized. Not just hospitals, medium-sized, large hospitals. There are lots of RMPs, single-bed clinics, 5-bed clinics, 10-bed clinics. Along with that, there are many pharmacies or prescribing over-the-counter medications. There are many laboratories, and there are many non-allopathy practitioners, multiple numbers, many millions, prescribing, TB drugs. So this actually is a major problem. If there are few things which you want to take from this lecture, this is one of the major key point you have to take it out. Private health sector, non-engagement of private health sector in TB control program is a major deterrent in achieving TB elimination in India. Okay, so we know from statistics that nearly half of TB patients, this is half of TB patients, don't go through the national TB program, even though it's free, even though it's cheap, cost effective, they don't go through that. They take treatment from private sector for various reasons, for convenience, for ease of, they use their mistrust in government practice. So it could be multiple reasons, but so nearly half of them don't take TB treatment from the government sector. So what happens is that half of them don't get notified. So I was telling you earlier that there are of 3 million TB cases, only 2 million get notified. But if you look at this statistic alone, nearly half of them won't get notified. Okay, so there is a big gap in TB notification in India, and this is intertwined with the fact that we don't have a robust reporting system from the private sector. Now, what is the government doing? The government is doing lots of things. First of all, they have made TB notification mandatory. Okay, that was done in 4 years ago, and they brought in a new app called Nikshay. It's got a mobile app and a web-based surveillance app, and now government has now given lots of perks. If you are a private practitioner, if you notify a TB case, you get 250 rupees. If they complete treatment every month, you get 250 rupees. And, and in total, they get somewhere around 2,750 rupees. And for another 24 months, if you're a drug resistant patient, if you're treating them, you get 6,750 rupees. So they are giving lots and lots of incentives to encourage private sector participation. And this is an unprecedented move by the government to engage. And without private sector participation, we will not be able to achieve TB elimination in India. And that will be the major game changer. And we all, as private practitioners, I know a lot of people are private practitioners in the meeting. I think it's very important for you to participate in this TB control program. So finally, there are some of other miscellaneous factors. For example, the current directly observed therapy rate is only 50 to 70%. So it's very rigid, very tight, but I think it's the key thing for the TB control program. There's a big stigma in the society. People still don't want to reveal they have TB. And you can see that Amitabh Bachchan comes in on every year for TB Day. He himself declares that he's at TB. We have multiple actors, actresses, prominent people coming and advertising against the stigma. And another important point is there's a big push to make a lot of new TB drugs as generic. And even today, I read in newspaper that bedaquiline was awarded, is going to become a generic drug in India. Supreme Court has turned down Johnson & Johnson's request to renew their patent. So good news. A lot of people with drug resistant TB will be able to access, and a lot of advocacy has gone through in ensuring TB patients receive these drugs. Okay, and finally, lack of standardized guidelines has become a major problem for the TB control program, and I think government is working on making the guidelines standardized throughout the country, so all of them access TB care appropriately. Okay, so just want to conclude this lecture seminar by saying that we are seeing a constant growth in TB, partly because one of the key things is that we've got constant population growth, and we've got other factors like diabetes, HIV, and we have other social determinants like poverty, and that's driving the growth. And the one key thing here is that private participation in India is the key to TB elimination. Without private participation, we will not be able to eliminate TB, and that will improve TB notification. Will actually get the impact of TB in the country. Until now, we don't know the actual true burden. We've got a national prevalence survey going on, and I think we'll get some true statistics out of that. And there are lots of lessons to be learned from other programs like HIV. You can see that in this slide, we were able to control HIV very well in India with all the constraints. And if we put our mind and effort into it, we will be able to do it. So, so just to conclude the lecture, the key point here is that private sector participation is key, and strongly encourage everyone to follow the government DOTS program, because that's the key program, because they have a standard monitoring for patients. It's free of cost and cost effective, and that will ensure we reach TB elimination, if not in 2025, at least in 2030. Okay, So with that, I'll conclude, and thank you for listening. And I will close the seminar, and we'll open up for some questions. Thank you.
Thank you so much, sir, for taking your time out for us and giving such a wonderful session on the special day, World TB Day. It was really a great session, sir. So before we go to the questions, can you please tell us a little bit about yourself, how your journey has been till now, how it has been so far, what are the challenges you have encountered?
Yes, I think, I got interested in, my first job was in an HIV clinic, and I got exposed to research at a very early stage, and felt that you could do a lot more than treating patients. And I was talking about the social determinants, and I got really interested in the social determinants aspect. I saw that how poverty, environment, and other social determinants play a major role in a person's health. And then went to US, and then went to Australia to pursue my public health. Started did some research in tuberculosis, got my PhD, and then continue as an academic. But I'm also working as a clinician in a hospital in Australia. Helps me to balance both, achieve the clinical, keep my clinical practice intact, and also translate some of my research and teaching back into my clinical practice, and vice versa. So, so if you have any interest in, public health, or if you're interested in the social determinants aspect, the broader aspects of medicine, I think, public health is a useful field, a very important field. COVID has highlighted how important public health issue is. And when I was a medical student, we were never allowed to wear masks to go see a TB patient, because they were very particular that there's a, they don't want to upset people. But now we see people wearing masks all the time. So it's changed so much. Then public health knowledge and the level of awareness has changed. So all of these things take a time, and it's a good transition personally for me to see how the things are progressing with the level of digital technology available, and newer tools like artificial intelligence available for for disease control. Even for TB, we do a lot of research in digital technology, using AI, and then using mobile apps. So all of these things are very exciting, and I'm fortunate to have both research, teaching, and then a clinical practice all on side by side, and able to build my career in that. So that's encourage people to pursue whichever field they like. Yeah.